Well, I'm delighted to be joined again by Professor Robert Clancy from Australia. Professor Clancy holds the Order of Australia for services to medicine and immunology. He's an emeritus professor of pathology and still does some work as a consultant physician. So, Robert, thank you for coming back and welcome, of course.
My great pleasure, John.
Robert, there's a few things I've been mulling around in my mind, and it's good to get some outside confirmation or indeed contradiction if it turns out I'm wrong. But we believe that the UK government is planned a cooperation with Moderna to produce 250 million messenger ribonucleic acid vaccines a year in the UK, and there's a similar plan to producing 100 million doses of mRNA vaccine a year planned for Australia. And we believe a similar plan for 100 million doses planned for Canada. Now, this is not talking about the COVID vaccines specifically, but my thinking is this: that when you give an mRNA vaccine into the arm, some can go into a vessel, and even if it doesn't, there's a degree of systemic administration. And I think especially if there's an inadvertent intravascular administration, or there's a damage to the blood vessel and some vaccine leaks into a blood vessel, because we know often after the vaccines there's a little bit of bleeding, so that can clearly happen. But either way, you're going to get some systemic absorption. This is going to go into the circulation. And because the mRNA is surrounded by fatty material, that will absorb into any fatty cell, and of course all cells have fatty phospholipid bilayer membranes. So the way I see this, Robert, is whenever you give an mRNA vaccine, it's going to go into a cell, potentially the myocardium, for example, potentially the brain, potentially the testes, the ovaries, anywhere really. That cell, the genetic apparatus in that cell, is going to produce the antigen and express that antigen onto the cell surface. And then there's going to be an immune inflammatory response to that antigen on the cell surface. Is there something wrong with that reasoning? Is that roughly the way you understand this?
John, I think that firstly, that's absolutely right. We know that the messenger RNA vaccines are systemically spread. We know that from post-mortem studies and various even endocardial biopsy studies in humans with myocarditis following vaccines, we know that these cells are producing antigens, in this case spike protein, on their surface. We know that spike protein can be found in the blood for weeks, at least weeks, after the vaccine. And something that has probably not discussed much, but probably should have, is that when the cells take up the messenger RNA, many of these cells, even locally, circulate. They don't stay where they are. They're not static. And so there is no question that messenger RNA is going to be expressing its antigen, its protein that it's coding for, throughout the body. Now, this is like having a foreign new antigen on the surface. And it's not just confined to spike proteins. Any messenger RNA vaccine using the technologies and methodologies that have been rapidly developed and not tested in humans, and that I think is the critical issue, rapidly developed, not tested, is going to be expressing its antigen, be it a flu, whatever, as a foreign antigen on cell surfaces throughout the body. And what we know from the information that's now coming out and has been coming out for a while is that the body sees that as a foreign antigen. It becomes like an autoimmune disease. The body is firing itself off against those cells. This is crystal clear. This is not hocus pocus. This has been demonstrated. And I personally believe that this is underpinning the groundswell of concern that I notice even in the British press today. I think there was a cardiologist calling for a cessation of the genetic vaccines until we sort this out. I think part of the problem is, firstly, that I have never seen evidence that a genetic vaccine is better than a good old-fashioned ground-up antigen. Never. There's no evidence that I have seen that suggests that it's better. They haven't. Where it's been, the only comparison I've seen was a flu messenger RNA vaccine, and it showed no benefit over the control split vaccine for flu. Why would there be any advantage? Secondly, the problem with the messenger RNA vaccines is that you have no control over the amount of antigen that's being presented to the body's immune system. And if many of the people watching this have done Immunology 101, and probably the first thing they were shown was a curve showing that the response, the immune response, and remember that's what we're looking for with a vaccine, to get a good immune response, depends on the amount of antigen. And you get this bell-shaped curve where you have, at the beginning, very small amounts of antigen, and you get tolerance, you get turn-off. Then you get a good response, and then it goes down again. And so the amount of antigen being presented to get an appropriate, effective, protective immune response is critical. And that's been sorted out with the old vaccines because we work out how much antigen you need to put in, because it's not going to change. It's not going to go up or down, which it will with the genetic vaccines. So we have no idea. Now, there's some data coming out now, which maybe later we'll get to talk about, which suggests that this is exactly what's happening, particularly with the messenger RNA vaccines, where we're getting, all of a sudden, we're getting differences from the DNA vector vaccines, where we're finding that you're getting more tolerance, more turn-off, because it suggests we're getting this high zone tolerance. So the problems are several. The first is that you're creating, if you like, systemic autoimmune disease. And I don't think anybody who understands and is critical can deny that. Secondly, we're getting uncontrolled amounts of antigen. And this will apply with any of the vaccines. Now, there's a bit of a rider. I was looking at some very interesting data, which is to do with cancer immunotherapy. In cancer now, there's a big move towards personalised immunotherapy. In other words, you identify the unique characteristics of your cancer cell or my cancer cell. You then manipulate the immune system so that it will effectively target that. But my one would not probably work for you. And I can see advantages in using the screening technologies of genetics to come up with a unique messenger RNA vaccine where probably you're talking about stage 4 cancers, you don't have quite the same level of concern as you would for, say, a 10 or 12-year-old boy. The other issue with the messenger RNA vaccines that no one wants to even think about is that we have what's called a reverse transcriptase. Now, that's an enzyme that exists in our cells that can take the messenger RNA and convert it back into DNA. And what we have no idea about, we know that can happen, it's been demonstrated, is the implications of that in the individual by changing the DNA. Are you producing a potential cancer risk? Or if it gets into the germline, are you producing a risk for transgenerational expression? Now, we don't know. We don't know these answers. And to go to your point, to have in my country, in your country, in Canada and America, where the people who have no understanding of these issues are advising government, oh, look, give us lots of money. We only want $1 billion. We'll produce all these messenger RNA vaccines for you. It is crazy. It is the craziest thing that I have seen. And John, what I actually, I'm not just complimenting you, but you've actually worked this out. And you're not, well, you're a biologist, but you're not an immunologist. Why isn't everyone else working this out?
Yeah. If I can work it out in my back room at home,
sort of you think.
Yeah.
Everyone should be working it out, and they should be screaming and saying, "Hey, wait a second! Look, this may eventually become the best thing since crisp bread." But right now, all of you understand that this vaccine we're having at the moment, the messenger RNA vaccines, has never been effectively put in humans before, except one or two where it didn't work very well. So, this is a massive experiment. The vaccines are actually registered as experimental vaccines. No demonstration that they can even be made faster, because if you go back to the early flu pandemics, they had vaccines working for back in 50s and 60s within 6 months. It took a year to get the... So, the disinformation about speed is partly true. I know that that they will develop the technologies, but they've got to learn how to confine and control the responses. And that is a long, long way off. Right now, we don't have that. Does that make sense to you?
It does. So the old what we could call the old traditional vaccines that we use all the time to suppress terrible infectious diseases all around the world.
Roundup bugs, yeah.
The type of vaccines that eradicated smortpox, for example, massive medical successes.
Oh, smallpox is a bit different. Oh, well, yeah, no, yes, you're right. The modern smallpox ones, yes.
Yeah. So they're actually giving an attenuated, as you say, a mushed up version of the virus. We're giving a controlled dose of antigen.
Yeah.
We know exactly how much we're giving, and presumably we know roughly what the half-life of that antigen is.
Yes.
When it goes into someone.
We do with the classic vaccines. The toxin vaccines for diphtheria, tetanus, the inactivated bacterial vaccines, inactivated viral vaccines. Even the live viral attenuated vaccines, we're giving it against the background of knowing what the live non-attenuated virus would do. We don't have any of that information for the genetic vaccines. It's to me, very, very scary. I passed some of this information to a friend of mine who is one of the world's leading epidemiologists the other day. And he was completely oblivious of it because he's not an immunologist. And he said, geez, that's scary. That's really scary. And I think we have to get this message to people. The governments have to be advised by people who understand and are not conflicted.
Well, when we give a fixed dose of the mRNA vaccine, but what you're saying is that could produce a completely different volume of antigen in me as compared to you.
Absolutely, and it does. It almost certainly does, because it's regenerating. It's getting remade, and you're getting more and more of this. And once it's in the cell, it actually produces antigen much longer than I think the people who first developed these considered.
Well, at first we were told it would produce
like
antigen. Sorry, Robert. Go ahead.
No, that's okay.
At first we were told it would produce antigen just for a few days. But now that's less certain.
We were, weren't we? They didn't have a clue. They didn't have a clue.
Oh, that was a guess.
Didn't have a clue.
Okay.
Well, I hope it was a guess.
Yeah. But it could be days.
One of the things
it could be weeks.
I've been dealing with immunologists. I've been dealing with immunologists in big pharma companies all my working life, and I probably shouldn't say this, but their focus is basically keeping their job. They have a role to focus on a particular tiny thing. Anything outside of that area is something they don't take into account, and I won't go into specifics, but it has blown me away, the lack of broad-based thinking that occurs. The total focus is producing a commercial product.
The other thing I hadn't realised till this conversation, that as well as having systemic absorption of the vaccine, even locally the vaccine will go into the immune cells, but then the immune cells can move around the body. Is that right?
Of course they do. And that is something that I've not seen anybody comment on, and yet anyone who has broadly involved in immunology knows about the plasticity and the movement of cells. They move all over the place. You get a tumour of the immune system. It's not like a tumour of the lung, which spreads away. It's all over the place, like a lymphoma, because the cells are moving around everywhere. In fact, the only thing that stops them moving is they become particularly nasty cancer, lymphomas. But you get lumps all over yourself because the cells are moving around.
And of course, in physiology, this is useful because if you get an infection, say, in your thumb, you want the cells carrying the information about that type of infection to go to your lymph nodes to generate a full immune response.
Absolutely. Mm-hmm. Absolutely. And this concept of it's called cell homing. The cells home. They have like postage stamps on their surface, which we call, and they go to a receptor, which is on the lining of the very, very small blood vessels, and they pop out wherever the receptors are. And this whole area of cell homing and migration of cells, T cells and B cells, is a critical part of understanding modern immunology. And so, if you put messenger RNA into your arm, it's going to get picked up by cells that are not just immune cells, but other cells which are also moving around the body. There's nothing localized about it.
Mm-hmm. Mm-hmm. Yeah, it's amazing.
We know this. You know that one of the common side effects of vaccine is they get a sore arm pricked where the cells have moved off to those lymph nodes.
Oh, so you get pain under the arm as well as at the injection site?
Yes, you can. Yeah.
It's amazing that the immune system is like this postage system with cells moving around the body. It's quite amazing. You put an address on it and it drops off to a...
Yeah, I think they're even called addressons.
Yeah.
But you do. You have a little address, you have a postage stamp, and it says, take me to the lung, take me to the lymph node, take me to wherever you want to take me.
So when I was 18, I had to do a medicines round assessment as a first-year student psychiatric nurse. And the charge nurse had come in and he said, right, what do you have to get right about giving out drugs? And you have to say the right dose of the right drug to the right patient via the right route at the right time. And if you didn't go do that, you failed. The assessment didn't go ahead. So we're actually saying now...
As you should.
Yeah, of course. The right dose, the right drug, the right patient, the right route at the right time. So what we're actually saying is that with these mRNA vaccines, you can't control the dose. I find that terrifying.
You can't control where they are. You can't control where they go. You can't control how much of the antigen they make, and you can't control how long they do it for. So, in a sense, it's all about you can't control. Once you put something into the body, you cross your fingers and hope it does the right thing. Now, with traditional vaccines, with 130, 40 years experience, and based on understanding the biology of the infection you're dealing with, we have a pretty good handle on this. With these aren't vaccines we're talking about. They're basically gene products. It's genetic engineering, and and I have nothing against the idea, but I think it's going to be terrific. For certain cancers. I think personalised cancers, I was just blown away by what they're now doing and the results they're getting in melanoma. I was talking to a friend of mine who's looking at with stage 4 melanoma, looking at this, and so I put a lot of effort into trying to understand. I could see, but to then move from that into routine vaccine, tetanus vaccines, things like this. Wow,
I mean, it's two completely different things in my mind.
A lifelong clinical immunologist, my job in Australia for many years was the go-to person in advising on vaccines, which I did wholeheartedly. I'm a great vaccine supporter, and it breaks my heart to see that I'm having to say these sorts of things.
I mean, my thinking's simple. If it's producing an antigen in different parts of the body, by definition, that's foreign. That's what an antigen is. It's something that the immune system recognises as being foreign. And you're going to get an inflammatory reaction to that.
Well, you can have self-antigens too, but it's recognition. Yeah, recognition.
Mm-hmm. I mean, I can understand it in cancer, because if you took some of the genetics of that cancer and you made a vaccine which was bespoke to that cancer,
yes.
You then injected an mRNA vaccine which was going to stimulate the body's immune system to attack that cancer. That's specific to that individual. I like exactly individualized medicine.
Yeah.
Individualized.
That's exactly what. I mean, it's very, very exciting. Very exciting.
Individualized assessment. I mean,
this is going ahead. Many people watching this would know that we now can take people's T cells and send them off to a laboratory, I think the only ones in America, and you send some of the antigens and they educate your T cells, send them back. I mean, we have another friend who has had long-standing lymphoma, and she is now in complete remission for the first time in 18 years as a result of this bespoke, specific, personalised T-cell education. And that's another variation, is using messenger RNA to identify in the code of genetics what the unique antigens are in that individual, and then make a very specific vaccine against those only. That makes a lot of sense, but it'll be particularly good when they sort out the biology, how best to do the messenger RNA immunisation.
That really makes one heck of a lot of sense because it's individualised. But this one-size-fits-all approach to vaccination is the absolute antithesis.
Very different.
Of individualised medicine.
Very different.
And I find that really concerning. And the other thing, of course, there is the risk-benefit analysis. So someone's got a life-threatening cancer, a systemic melanoma, for example. And, well, basically, they have no hope without treatment. So anything is worth a try. But
well,
for someone who's already healthy.
The data that, the data that Merck has just released, I'll spank me if I've got it wrong, but they were looking at stage 4 cancer that they've removed the big bits, the bits they know are there. The relapse rate in 6 months would be 80% with nothing, 40% with the current checkpoint inhibitors, which is a breakthrough, 20% recurrence if you combine the checkpoint inhibitor, and we'll get onto that when we talk about immunology later, that if you combine the checkpoint inhibitor with the bespoke vaccine, it's down to 20% at 6 months. I mean, that is huge. That is huge.
But these are people at high risk.
We do know some of these companies.
These are people
I was going to say some
risk.
of these companies don't always get it right.
Oh yeah, there's great stuff. There's great stuff there.
Well, absolutely high risk. They've got nowhere to go.
Yeah. So risk-benefit analysis to me is interesting, and to intervene in the life of someone who's currently healthy, you have to be quite audacious really to intervene in that situation. It's a different situation.
Who has their reproductive years ahead of them as well.
Indeed.
I think that's that's the scariest thing, and nobody can turn around and say that that's not a potential risk.
Mm-hmm. And the unpredictability is the other bit that really concerns me, that we can't work out how someone's going to respond in terms of the volume of antigen.
Absolutely, and
they're going to produce.
I think one of the things we've certainly learnt and become very clear about with COVID is that we're sort of traditionally thinking of health and disease and keeping ourselves in the health bracket. But what we've learnt with COVID is that within health, and they get COVID, you've got most people get little more than a sniffle, but some will get very sick and some will die. And so within the health bracket, we have this wide range. And to me, I wished I was at the other end of my career. This is what I'd be looking at. How do we move people? And I believe we can. There are ways we can do this. How do we move people within that health bracket to all be sniffles rather than hospital patients? And when you think about it, that makes enormous sense. And that is the big area that no one is addressing. We're coming up with vaccines, we're coming up with antiviral agents, but we're not saying, hey, wait a second, why don't we make everybody like the person who gets the sniffle? What's the difference between me with a sniffle and you in hospital, for example?
That is a good question. If we knew the answer to that, that would be really quite useful, wouldn't it? And obviously a field that...
Well, I think we can get those.
Yeah.
I think we can get those answers.
Yeah, absolutely. I'm sure we can. So the idea with increasing dose of antigen, Robert, so you get an increased immune response as the dose of antigen increases. And then as the dose of antigen increases further, the immune response reduces. Am I right about that?
Absolutely. And the traditional term for this is you have in the middle, you've got protective immunisation on both sides with low amounts of antigen, high amounts of antigen. We have non-responsiveness, and the term used is tolerance. We're tolerant. So we have low zone tolerance, high zone tolerance. And when we put in a messenger RNA and it's making who knows how much antigen over what period of time and where, you have no idea whether you're getting tolerance or immunity. And of course, this is exactly what we're finding in the people who are getting over booster after booster. There's no secret. They're actually turning off their immune response. We knew that from the British data over a year ago, 18 months ago. Now we're finding that the recent data in my own state of New South Wales, that everybody in hospital were multiply immunised. None of the unimmunised people were getting sick enough to get into hospital. That's just an overview, but we're seeing that repeated in your country, mine, America, all over the world. That what I've been trying to say for 2 years and writing in areas that no one reads because the mainline press doesn't want to know this, is that we have to learn, irrespective of messenger RNA or any vaccine, we have to learn how to space the vaccines so that we have controlled antigen and we do it in a controlled way, so that all the time we're getting a positive response, not risking a negative response, which is exactly what's happening at the moment. So we're actually getting over-immunised people, and they're getting more infections and more severe infections. And this is not a secret. This is not my view. This is what the data, the official data, is telling us. And no one wants to know it.
So with an mRNA vaccine, if it turns out that I make a very small amount of antigen, I'm not going to get a very good immune response. If we give the same dose of vaccine to you, if we give the same dose of vaccine to me and you make a whacking amount of antigen, that's actually going to have an adverse effect on your personal immunity by starting to turn your immune system off.
Absolutely, it certainly could. We don't know. We don't know.
I mean, the British government are still claiming that people that are getting the boosters are protected against hospitalisation. That's what their data seems to be showing. But what we're saying,
I think it's fair for them to say that. The data I've seen, and the British data, is that if you give, say, people have had their standard 2 vaccines, they have a booster, they'll have about a 30 or 40% less chance of going to hospital for a couple of months. And this period of relative protection is getting less and less and less as you keep giving more and more vaccines. And the reason for this is that, and we'll explain that, I hope, in subsequent talks on immunology, is that you must understand that COVID, like flu, is a mucosal infection. And the mucosal, where you get the infection initially, provides the game plan of what's going to happen downstream. And the game plan for a mucosal infection is it spreads throughout the body, not only good positive cells that will give you a positive response, but at the same time it cells what we call suppressor T cells. And so always you've got a balance. And this is what's different between, say, measles and COVID. When you come along with a second measles vaccine, you get this brilliant, terrific response because you have very few suppressor cells. But because you've got a COVID infection generated as a mucosal infection in the lining of the airways of the lung, you get a lot of suppressor cells, which the more you stimulate, the more it dominates the response. And so the more you do it, the more you get, the less time you get protection. I've got a slide which I've included in the subsequent talk, which was the first thing I ever did when I was working in Canada. And I couldn't understand why it was that in rabbits, when I kept putting in vaccines, I only got T cells responding for 2 weeks. And now, of course, we understand why. And this is exactly what's happening with COVID.
So we've got these B cells that are producing the antibodies, just to look at it fairly simply. They can be stimulated by T helper cells. But then when it's time to stop making the antibodies, the body has to have a suppressor cell that also stimulates them with a different cytokine to turn them off, which is necessary in a physiological situation. But repeated doses of mRNA vaccines, for example, are actually stimulating the suppressor cells and actually reducing
Absolutely.
the immune response.
Well, it's the antigen that is being made that will stimulate whatever cells that are there. And if you've had an experience and a history of building up a lot of suppressor cells, then obviously it's night follows day. It's Immunology 102 maybe, but it's very simple stuff that you're going to get a net negative effect, not a net positive effect. And that's exactly what's been found. And with great surprise. Why it's a surprise is basically says that people involved who are making decisions haven't got a clue about basic immunology.
Which gets us back to the original problem. Given that our governments have decided to spend so much on this, when this obvious theory that you and I have elucidated in this video it becomes obvious, then presumably they're going to have to shut these plants down or simply use them for cancer vaccines. They're going to be a bit of a white elephant, aren't they?
Well, it'll be very interesting to see. I mean, you cannot keep this information suppressed forever. And I think you're right. I think you're right that the wriggle room will be individualised cancer treatments. That's my bet. Because remember, and I said this earlier, that there's not a jot of evidence that a messenger RNA vaccine is giving you better protection where in traditional vaccination than a ground up bug, virus or whatever, or an attenuated bug in the context of infection we know and understand. There's not a jot of evidence that's any better. But
so there's no benefit. There's no benefit.
We're talking about $100 billion a year. Pardon?
Yeah.
Sorry.
Yeah, I was saying that there's no benefit because all you're doing is getting the body to make an antigen instead of giving an antigen. But you've got all these risks of systemic inflammation. It's just a no-brainer not to.
Well, it's worse than that, John, because quality control has really been the dominant factor. Quality control and safety are the dominant factors traditionally in the pharmaceutical industry, as it should be, controlled by regulatory organisations like our TGA, FDA, and your own and European regulatory agencies. Now, what is happening now is this control process seems to be very shaky. And we've just in Australia, we've found batches are getting through great variations, very poor quality control. They haven't even developed the experience of knowing what quality control processes they should be using, because you're finding that you've got a messenger RNA is very unstable, a little bit breaks down. You've got new delivery systems, processes that involve getting the messenger RNA into cells is being put into vaccines. We know very little about those. It's the uncertainty of what you're actually injecting on the quality control is just not good enough. And that's come out with batch variations and things like that.
Why on earth did we go down this route in the first place? Why did we go down the adenovirus vector?
I don't get involved in that. Look, I hear the same things you hear, and I try to keep away from the politics.
Scientifically,
I'm just
to me,
a simple pile.
I think what we can say as scientists, it doesn't make a lot of sense to you and me.
Yeah, I'll stick to that.
Yeah, what wise answer? Yeah, what I was trying to get at is there some clever scientific answer that I'm not aware of, but I don't think there is. It's
No, I think the dollar sign's pretty important.
Yeah. Well, messages to
See,
our governments,
John,
then,
we've always worked for public. We've always worked for public systems. It's easy for us.
That's true. Yeah. So, message to the Australian, British, and Canadian governments: really, check out your science before you invest your billions of dollars in an untested new biological technology.
Do not hear it. I don't know. It's going to take an explosive events to bring them to heel. It's so scary, isn't it? I actually feel sorry for a lot of the politicians because they're listening to advice. But remember, they're listening to people who want to get the $100 million to develop, have the thing going in their particular building, in their backyard, and their university. It seriously is a very corrupted system.
Or maybe Robert will listen to
these are
this
friends
video
of
and
mine,
change
Bob.
their minds.
Well, maybe I'll be deregistered next week.
Yeah, I could be quite a few things by next week, but that's out of our hands. Professor Clancy, as always, total delight, absolutely fascinating. So pleased you've come on, and thank you very much. And we'll look forward to just how this is received around the
As
world.
always, a great pleasure, John. Yeah.
Thank you, Robert. Thank you.
Thank you.
I just like that